Thank you. Thank you, Tracy, for kind introduction. I'd like to begin by thanking Tracy Lynch from Wolfram Syndrome UK and Stephanie Snow-Gabel from the Snow Foundation for organizing this important webinar series. So I am Dr. Fumi Urano. I am the Samuel E. Schechter Professor of Medicine at Washington University School of Medicine in St. Louis, United States, and I direct the Wolfram Syndrome Clinic at BJC, and also direct the basic science and clinical research programs at Washington University School of Medicine. Today, I will talk about our therapeutic development for Wolfram Syndrome. Okay, so can you see my screen? Okay, it's good? Okay, all right. And this is the joint presentation with the Dr. Mathia Leinders and Dr. Jamie Timmons from Amylyx. Okay, here are my disclosures. And my research on Wolfram syndrome revolves around extensive collaboration, as you know. And I have partners both in the United States and around the globe, including patient organizations spanning various countries, including Wolfram Syndrome UK and the Snow Foundation and other patient foundations. And we have been closely working with the Dr. Barrett team in the UK. He is the pioneer of the Wolfram Syndrome research, as you know. And I am so grateful for their collaborative spirit and generous sharing of their expertise with my team. So thank you, everyone all over the world. Today, I plan to talk about 4 things. I plan to summarize 2 types of Wolfram syndrome and related disorders. And then I will share lessons and stories from past and current Wolfram syndrome clinical studies, including clinical studies and clinical trials. And I will stress the importance of progressing gene and regenerative treatments for Wolfram, because Wolfram is the degenerative disease and genetic disease. And finally, I will emphasize the need for cooperation with patient organizations and industry partners to support their development of new therapies. So here is the structure of my talk. So what is Wolfram syndrome? Wolfram syndrome is characterized by juvenile onset diabetes mellitus. Median age of onset is 6. And there are some treatments for diabetes, as you know. Optic nerve atrophy starts around age 11, and there is no treatment for this, as you know. Deafness starts around age 14, and there are some treatments for deafness. Deafness, many patients are not aware that they have deafness because it starts as the high frequency hearing loss, which does not affect their day-to-day activities. Diabetes insipidus starts around age 13, and so diabetes insipidus is different from diabetes mellitus. Diabetes insipidus is a medical condition that causes the fluid, water in the body to become out of balance. That prompts our body to make large amounts of urine. It also causes a feeling of being thirsty even after having something to drink. So this is caused by a lack of hormones secreted from our pituitary gland in the brain. And there is a treatment for this, DDAVP. That's a synthetic hormone. Neurodegeneration begin to appear during the later years of adolescence in a classic form of patients with Wolfram. And there are 2 causative genes, WFS1 and CISD2. There are 2 types of Wolfram syndrome. Wolfram syndrome type 1 is caused by mutations in the WFS1 gene or pathogenic variants in the WFS1 gene. And Wolfram syndrome type 2 is caused by mutations in the CISD2 gene. Most patients have Wolfram syndrome type 1. Higher than 95% of patients with Wolfram have Wolfram syndrome type 1. Prevalence is 1 in 250,000 to 700,000. And we have reason to believe that this number of patients is an underestimation of the actual count based on the data collected through our clinical studies. And I will discuss this later in my talk. Patients have 2 mutated copies of WFS1 or CISD2 because this is an autosomal recessive disorder. As you know, we all have 2 copies of WFS1 gene, one from our father and one from our mother. And if we have just one mutated copy, we have no problems usually. And these people are called carriers. And usually parents of patients with Wolfram are carriers. They have one good copy, one mutated copy. And if a patient inherits mutated copies from both parents, a patient carries 2 mutated copies, then a patient develops Wolfram syndrome. Through our clinical studies, we learned that Wolfram syndrome type 1 is a spectrum of disorders, which means some patients have mild manifestations, while the others have more severe manifestations. And there are reasons for that. Females tend to have milder symptoms than males. Also, patients who carry 2 or 1 missense WFS1 variants, they have milder symptoms. This is a technical term, but my point is that there are specific types of mutations that are associated with milder forms of the disease. And patients who carry 2 frame shift, 1 nonsense WFS1 variants have more severe symptoms. And 40% of the patients in our cohort, we have around 500 patients in our cohort, they belong to this category. And they have a classic form. Also, we have recently identified an interesting WFS1 variant associated with the mild form of Wolfram syndrome. These patients may not have diabetes or optic nerve atrophy at age 20 or even age 30, but later in their lives, they may develop diabetes or optic nerve atrophy, or maybe they may develop both. And this variant, we call it WFS1P arginine 558 cysteine variant, is a common variant in Ashkenazi Jewish population, and the carrier frequency in Jewish population is 2.5 to 3% in the United States. So prevalence could be based on these calculations. Prevalence could be 1 in 70,000 in the United States, and there may be 5,000 patients in the United States. In addition, we identified Wolfram syndrome related disorders. These patients have only 1 mutated copy, but they have developed different types of medical conditions, such as hearing loss and optic nerve atrophy only, or diabetes only, or developmental delay, intellectual disability, diabetes, cataracts, hearing loss, hypotonia, ataxia. These patients have only 1 mutated copy, but they have developed multiple different medical conditions. And so, as I mentioned, carriers also have only 1 mutated copy, but these mutated copies are different from the mutated copies that carriers of Wolfram syndrome have. So we have been studying this type of group of diseases. So we have been collecting medical records, biological samples to understand this group of disorders, WFS1 related disorders. So if you have any patients with this disorder, please refer them to us. So to summarize, Wolfram syndrome is characterized by having diabetes mellitus, diabetes insipidus, optic atrophy, hearing loss, and neurodegeneration, and they have 2 mutated copies. This is a spectrum of disorder. Some patients have mild manifestations, and some patients have more severe manifestations. In addition, there are other medical conditions related to WFS1 gene mutations. Through our clinical studies, natural history studies, and registry studies, and we identified other complications of Wolfram syndrome in addition to diabetes mellitus, diabetes insipidus, optic nerve atrophy. Neurogenic bladder is one of the major complications of Wolfram syndrome. And so many patients cannot control the movement of bladder, and they cannot sense the amount of urine, or they cannot push out the urine from their bladder efficiently. And this is part of the neurodegeneration. And so this may lead to accidents in adults, which is embarrassing. And also, if urine stays in the bladder, that can lead to urinary tract infection, which is also tough. And some patients have to do a self-catheterization to remove urine. So this is a difficult complication of Wolfram, and also very common complication. And the GI-related complication is also common, And also respiratory failure is one of the most scary complications of Wolfram syndrome. And this is related to brainstem atrophy, which is part of neurodegeneration. Because brainstem controls our breathing, in some patients, they have problems in their breathing, and so this can be prevented by conducting sleep tests, and also by providing positive pressure. We can actually prevent respiratory failure in many cases. Choking event is also common and one of the complications of Wolfram syndrome. And this is also related to the brainstem atrophy, because brainstem controls our swallowing. So the swallow test can assess your swallowing ability, and also by consulting with speech pathologists, you can certainly prevent the choking event. So these are the major complications of Wolfram syndrome. And so we provide their consultations and medical advice or medical tests through our Wolfram clinic. So please, if you have any patients with Wolfram syndrome, please refer them to us. There's email address and phone number here, and we accept both international and also patients from different states in the United States. As was discussed today, because Wolfram is a rare disease, many doctors don't know how to manage Wolfram syndrome patients. And so we need consensus clinical guidelines. So we are trying to create consensus clinical guidelines together with the NODE and the Rare CAP program. So this is the Rare CAP is a rare disease clinical activity protocol program. And so this is a cloud-based system to create clinical guidelines. So if you are interested in contributing to this activity, important activity, send us email at wolframsyndrome@wustl.edu. Through our clinical studies, we learned a lot about Wolfram syndrome, but we need treatment for Wolfram syndrome for sure. And here is my 3-step formula to achieve a cure for Wolfram syndrome. First step is to slowing progression using oral medications. Step 2 is to halt progression through gene editing therapy. And step 3 is to revive damaged tissues through regenerative therapies. And these could be developed in parallel. To develop new treatments, we need to understand the mechanisms of the disease. In the past 22 years, my research team has been studying the mechanisms of Wolfram syndrome and revealed that Wolfram syndrome is a prototype endoplasmic reticulum disorder. Endoplasmic reticulum is a cellular compartment executing many different important biological functions, including the regulation of cell stress, regulation of cellular calcium homeostasis, and also they are controlling the production of newly synthesized protein. Loss of function of WFS1 protein caused by Wolfram gene mutations can lead to high levels of endoplasmic reticulum stress, which is a type of cell stress, mitochondrial dysfunction. Mitochondria is important for producing energies in our cells, and also dysregulation in cellular calcium. homeostasis. So here is the molecular mechanisms of Wolfram syndrome and therapeutic development strategy based on molecular mechanisms of Wolfram syndrome. When considering the molecular mechanisms of Wolfram syndrome, I want you to think this as a river. It's just like a river. Like a river, there are upstream and downstream components. The very upstream of this river is, as you know, mutations in the WFS1 gene, which leads to subsequent endoplasmic reticulum stress and mitochondrial dysfunction. These molecular events trigger a cascade of downstream events, ultimately resulting in death and degeneration of insulin-producing cells in the pancreas, death or degeneration of retinal ganglion cells in the eyes, and neurons in the brain. The very downstream consequences of this river are diabetes, vision loss, choking events, and choking events and respiratory failure. So instead of clearly we need to treat the very downstream events, but our strategy is to target upstream, try to target upstream. And initially, we try to target endoplasmic reticulum dysfunction using existing medication, dantrolene sodium. So we identified dantrolene sodium through the compound screening strategy, and this drug has been approved for the treatment of different medical conditions. And we started preclinical studies in mice and cells around 2010. We completed preclinical study in 2014. We started a clinical trial in 2017. Then we completed our trial in 2019. 19 patients completed phase 1b/2a study. And we published the data. And in short, we did not see statistically significant difference on diabetes-related outcome measures, vision, and neurological functions. We did find some responders out of 19, but that was not good enough. However, we learned lessons from this dantrolene drug repurposing trial. Drug repurposing trial is definitely less expensive than developing new drugs. And because when we started this trial, the generic drug was already available. Also, we can speed up the drug development process because we already have safety data and other data. We learned a lot about how to create a clinical trial protocol. And Dr. Barrett helped us write up the clinical trial protocol, and I learned a lot. We also learned that 30 minutes mixed meal tolerance test to assess diabetes was not sufficient. And we also learned that diabetes or visual acuity could improve during the duration of the trial. So that was interesting. We had challenges. Clearly, the drug was not designed for Wolfram and also limited patent protection, which can limit financial incentives for pharmaceutical companies to invest in this type of drug. So we shifted our focus towards new drugs around 2017. And then we identified a investigational drug, AMX 0035, developed by Amylyx Pharmaceuticals in Cambridge, Massachusetts. And this, based on the chemical structure of AMX 0035, we realized that AMX 0035 could reduce endoplasmic reticulum stress and improves mitochondrial dysfunction. So the collaboration between Amylyx and our team at Washington University was facilitated by patient organizations, including Unravel Wolfram Syndrome, led by Dr. Sarah Gladstone, and Snow Foundation, led by Stephanie Gabel, and Eddie White Foundation, led by Bess White. So we started collaboration in 2017, and so co-CEOs of the Amylyx, Mr. Josh Cohen and Mr. Justin Klee, were very generous, and we started collaboration right away after exchanging few emails. And then in 2022, we completed preclinical studies. Then we started a clinical trial. We created a clinical trial protocol in 2023, and we started a trial in April 2023. So first patient was dosed on April 12, 2023. So we have been doing this exactly 1 year, and we decided to report the interim data. I want to share some preclinical data of AMX0035 in preclinical models of Wolfram. So we treat, so y-axis shows the cell death levels, and x-axis shows the names of treatment. And we created induced pluripotent stem cells from more than 25 patients with Wolfram syndrome. Then we differentiated them into brain cells. Then we treated them with AMX0035. As you can see, AMX0035 treatment reduced cell death significantly. Interestingly, PBA and TUDCA, these are components of AMX0035. Each of these compounds could also reduce cell death levels. And by combining them, which is AMX35, could actually even reduce cell death levels, we could see synergistic effects. We also created insulin-producing beta cells. It's called stem cell-derived islets using iPSC cells from our patients. Then we treated these insulin-producing pancreatic beta cells with AMX. As you can see on your left side, we could reduce cell death significantly, and we could also increase insulin secretion, which was really encouraging. And AMX0035 could also improve mitochondrial functions. That's part of the molecular mechanisms of Wolfram syndrome. So we published the data in 2023, and then we started a clinical trial April last year. And we have been measuring efficacy and safety in 3 different domains: beta cells, which is diabetes, visual acuity in eyes, and neurological functions. And so the participant takes the investigational drug AMX35 once a day in the first 3 weeks, then twice a day starting on day 22, and we assess their beta cell functions, visual acuity, and neurological functions at these time points at our medical center. How do we monitor diabetes? So we are using 2 different things: mixed meal tolerance test and daily insulin dosing and time in range. So mixed meal tolerance test is a method to assess patients' ability to make their own insulin from their own pancreas. And so Boost is a drink that contains high carbohydrate, lipid, and protein. We ask our participant to fast overnight. Then we put their IV line in the patient, and then we ask them to drink Boost at time point 0. We draw blood at time point minus 10 minutes, 0 minute, 15 minutes, 30, 60, 90, 120, 180, and 240-minute time points. And then we look at their C-peptide levels. C-peptide is an established marker for pancreatic beta cell functions. It's related to insulin production. And so we are supposed to see an upregulation of C-peptide during the mixed meal tolerance test. We have been also monitoring daily insulin dosing by downloading their data from insulin pump, and we are also monitoring the timing good range using their continuous glucose monitoring system to see if this medication can stabilize their blood sugar levels and can decrease insulin dosing. We have been also monitoring their visual acuity and retinal ganglion cell layer thickness via OCT imaging system. because we know that both visual acuity and RNFL thickness decline over time in our patients. So here is our clinical trial team. And so Stacy Hurst, our lead nurse coordinator, is preparing the AMX. So AMX 35 comes as powder in a sachet. Then a participant needs to dissolve it in water, then needs to drink it twice a day. Okay, so that's our AMX trial. And so Dr. Mathia Leinders and Dr. Jamie Timmons will report their interim data right after this. And in addition, we are also testing a sigma-1 receptor as a novel target for Wolfram syndrome together with Prilinia. And it's a biotech company in Massachusetts, and we are conducting preclinical study together with Prilinia, which has been supported by 3 patient organizations and donations. Unlabeled Wolfram syndrome, Eddie White Foundation, Snow Foundation. Very upstream mechanism of the Wolfram syndrome is Wolfram gene mutations. So we are trying to target Wolfram gene mutations by gene therapy, especially gene editing therapy. So we are trying to correct mutation to cure diabetes and other symptoms. Our proof of concept study using CRISPR-Cas9 could cure diabetes in mice. So we published in Science Translational Medicine in 2020. So we are trying to replicate this success in different tissues, especially eyes. And so we initially used gene editing method called CRISPR-Cas9, but now we are using prime editing and base editing. And so many people in my lab have been working on this project. Also, we have collaborators in Europe and United States, especially Samagria Banskora. She has been our generous collaborator. We are also developing regenerative therapy for optic nerve atrophy. So we are trying to introduce regenerative factor called MANF into eyes of Wolfram patients to improve their eyesight. And MANF is a neurotrophic factor. Neurotrophic factor is the hormone secreted in our brain to maintain our brain health. MANF is a unique neurotrophic factor because it confers protection against ER stress mediated endoplasmic reticulum stress mediated cell death, and also it could activate the proliferation of cells experiencing the endoplasmic reticulum stress. So we created humanized Wolfram syndrome mouse carrying Wolfram gene variants, WFS1 gene variants equivalent to human WFS1 gene variants associated with a severe form of the disease. These animals develop optic nerve atrophy very quickly. So we injected MANF into eyes of these animals, then we assessed their visual acuity. And so after 4 weeks, after 8 weeks, and after 12 weeks. On the right side, you see the visual acuity measured by contrast threshold. And you see on the left side, you see visual acuity assessed by optokinetic response. There are different ways to assess visual acuity in mice. Left side, optokinetic response. A higher number is better. Right side, contrast threshold, lower number is better. And so clearly, every week, we see a separation between the injected eye and uninjected eye. So this is pretty encouraging. And so we are trying to develop new therapies to stop the progression, regenerate the tissues, and also to cure the disease via gene therapy. Before I end my talk, I want to emphasize the significance of working with patient organizations. So we have been closely working with patient organizations, including Wolfram UK, Snow Foundation, Eddie White Foundation, Unravel Wolfram Syndrome, and other patient organizations all over as well, one from France, one from Italy. And so to work with patient organizations is very important to raise awareness and also to facilitate collaboration between industry and academic researchers like myself, and also collaboration between academic researchers. Improve clinical care is very important. So we have Wolfram Syndrome Clinic to improve our clinical care. And we need funds for research. So we need donations, grants, and also we need to work with the industry to develop and bring new therapies to our patients. So it takes a village to achieve a cure for Wolfram. So I want to thank my family and my mentors and my team members. And so before I end my talk, I want to dedicate my talk to my mother who recently passed away. And she was a fantastic pediatrician and a family doctor and greatest supporter of my research on Wolfram syndrome. And she actually published a paper on rare disease when she was a resident in 1965. Thank you for your attention, and I will hand over the presentation to Dr. Leinders and Dr. Timmons.
Yes, thank you, Dr. Urano. Also, foremost, thank you, Tracy. Thank you, Stephanie, for allowing us a couple minutes to present very exciting interim results here today. We have recently had a company webinar where we presented to the whole world our interim analysis on our Helios study. My name is Mathia Leinders, and I have the pleasure to represent the Amylyx family today. And as you remember, our clinical trial in Wolfram syndrome is called Helios. It was originally designed as a proof of biology signal finding study, and it is a 48-week open label treatment period followed by a 48-week treatment extension phase. And we have multiple analysis time points in this clinical trial. The first analysis time point is at week 24, and we will be presenting the interim analysis results today. As you remember, the key clinical trial criteria were Wolfram patients aged 17 years or older. They needed to have a definite diagnosis of Wolfram syndrome, and they needed to have stimulated C-peptide levels of greater or equal of 0.2 nanogram per milliliter. They needed to have insulin-dependent diabetes mellitus, must be willing to wear a CGM device for the entire study duration, and not be on GLP-1 agonists. The overall primary goal of Helios was to achieve slowing of Wolfram syndrome over our clinical trial. Very briefly, looking at the Helios endpoints here, we have bucketed in very different categories. As you just heard from Dr. Urano, we have on the left side the primary and secondary outcomes, where we look at C-peptide levels, further diabetic markers, but also look at visual acuity. Then we also look at general quality of life measures, further visual measures, but also neurological functioning. What we're presenting today is an interim analysis that we performed last month on 8 participants having completed the week 24 visit. These are the participant baseline characteristics. Now, this is the overview of all 12 participants since the study is fully enrolled. The median age was 25 years of age, with 2 male participants, 10 female participants, and an age range of 18 to 39 years. The median duration of Wolfram syndrome was 5 years, ranging from 1 to 24. The median age at diagnosis, on the other hand, was 20 years, ranging from 8 to 35 years. Below, you can see some median ages of onset of different symptomatologies. Diabetes mellitus, for example, the median age of onset was 9 years, ranging from 3 to 32 years. We had 4 participants that have diabetes insipidus with a median age of onset of 11 years, ranging from 7 to 24 years, vision loss 11.5 years, 5 to 29 years range, and hearing loss occurred in the median of 16 years, and then ranging from 7 to 33 years. Now this brings me to the analysis of our primary endpoint. Our primary endpoint is C-peptide. C-peptide, as you heard from Dr. Urano, is a protein secreted by the pancreas. It's secreted in 1-to-1 molar fashion, and it is a surrogate marker allowing us to look at how well the pancreas is functioning. Over time, based on natural history data, we have learned that C-peptide levels tend to decrease the longer Wolfram syndrome is curing. And as you can see on the right, it's a striking result. On the dotted black line is our screening measurement of the MMTT over 240 minutes, so a 4-hour mixed meal tolerance test. And then in orange, you see the week 24 analysis and also the week 12 analysis in light blue. As you can see, there is a positive change. We see an increase. We see 2 things here. A, that C-peptide is increased over time, but also the pancreas is functioning better by earlier peaking of C-peptide. So taken together here, the Helios interim results indicate improved pancreatic function and better cell responsiveness at week 24 compared to screening. We have further looked at secondary diabetic markers or downstream markers of C-peptide. On the right side at first, we also look at A1C, and you see that there is a decrease in A1C, which is a positive change. And you also see an overall improvement in the time spent in target glucose range, a 7.1% increase of time spent in these 8 participants. And both of these results also speak to an improved functioning of the diabetic system, so an improved glycemic control. We've also looked at visual acuity, as Dr. Urano explained. And as you can see here on the right side, Helios interim results show a trend towards visual acuity improvement. As you can see in green, there is a positive change trending towards improvement in visual acuity when you look at the best eye. We know from Dr. Barrett's studies, from many natural history studies, that over time, vision decreases, the visual acuity gets worse over time. And what we can see here, when looking at one eye, there is a trend towards slowing of that decline. We also looked at many exploratory endpoints. 2 of the most striking ones showed here, the PGIC and CGIC. As you remember, PGIC is the patient-reported global impression of change. The CGIC is the clinician-reported global impression of change, which are basically questionnaires for us to design to ask participants how well they're doing on Amylyx 35 and how well their status is improving or not improving in the trial. And as you can see, at the interim results, we show 100% of participants met the responder criteria by self and clinician assessments. And we see that at week 12 and week 24, there is either minimally improved or much improved reportings of field function or survival in this trial. When looking at the safety and tolerability, we can say that Amylyx was generally well tolerated. The most common side effect was transient diarrhea, as you can see here in the percentages and the listing on the right side in the table. This is very similar to our ALS and PSP and Alzheimer trials, and no new safety signals were identified in this new population. So taken together, we see in this interim analysis of 8 participants that there is a potential of Amylyx 35 in Wolfram syndrome. We see partial reversal in C-peptide phenotype. We also see an increase in beta cell responsiveness. We see improved glycemic control. We see a trend towards improved visual acuity, and we see much improved participant and clinician-reported outcomes. And with this, I would like to end our talk here. We extend our deepest gratitude to all Helios trial participants, their loved ones, also Dr. Urano and the Washington University site team, and the overall entire Wolfram community for their support of this trial. Every one of you have made this possible. You've helped one way or another, and the Amylyx team is very, very grateful for having the opportunity to present today. Thank you.
Thank you, Matthias. Thank you, Fumi, as well, for your presentations. It's really helpful. So we've got some questions coming in. So I'll make a start with these. What are the results of Amylyx on Wolfram animals? Also, how does it compare to GLP-1? Who'd like to answer that one?
Sure, so I can answer that one. So we treated animals with Wolfram syndrome with their food containing AMX 0035. So we put AMX 0035 in the food there. And then we looked at their diabetes and visual acuity. And very similar to the results we have seen in our patients. So we saw the improvement in diabetes. We saw improvement in diabetes measured by intraperitoneal glucose tolerance test. And we saw a trend to the improvement of visual acuity, but that was not statistically significant. And so we need to keep in mind, you need to keep in mind that we only treated animals for 3 months, short period of time. So it's a little different from what we are doing with the patient. And regarding the side-by-side comparison of GLP-1, we didn't do that. But that's a really good question. What we need to do is side-by-side comparison between insulin treatment, GLP-1 treatment, and AMX treatment. And also we may want to mix AMX and GLP-1. And so the reason is AMX 0035 was originally developed for neurodegenerative disorders, right? So GLP-1 was developed for diabetes. So GLP-1 for sure should improve diabetes. AMX is not supposed to improve diabetes, but we see an improvement, which strongly suggests that AMX 35 targets upstream mechanisms of Wolfram syndrome. This means the AMX could improve multiple downstream consequences, including vision and neurological symptoms. In short, we did not do a side-by-side comparison, but we are considering doing it. And we need to include insulin only, actually.
Okay, lovely, thank you. Is there an intention to transform Helios into a pill? Is there a marked difference compared to the results shown back then in phase 2 for ALS that are indicating higher success for Wolfram?
I am happy to take that one. I'm Jamie
Okay.
Timmons. I'm on the medical affairs team at Amylyx. So for the first question around the pill, having an actual pill of this formulation of the drug would be possible, although it would be a lot of pills to take. And so what we're looking into instead are different formulations. So we know that AMX 35 does have a bitter taste. And so looking into how we can create a formulation that has less of a bitter taste or no taste. That's very top of mind for us at the moment. And then also looking into if we can just lower the amount of liquid that needs to be ingested from, a full glass to perhaps less. So definite areas of interest for us to improve the experience of taking AMX 35, both from the taste and just the amount of volume that's needed to be taken. And then in relation to the ALS question, that's really tough. It's quite difficult to compare the two diseases. They're just very different disease mechanisms and very different processes. What I would say with Wolfram syndrome is that we do have these objective measures in terms of C-peptide, A1C, visual acuity, tests that we can, look at and really truly see an objective difference. Where unfortunately in ALS, we don't necessarily have great biomarkers like that. So that does help us on the Wolfram syndrome side in terms of our measurement of disease progression and whether or not the drug is working.
Lovely, thank you so much. Is there a time limit for how long AMX 35 could be prescribed, or is it something that could be for life?
So I could take that question. So I think patients with Wolfram syndrome may need to take AMX 35 for life, similar to how patients with hyperlipidemia take statins for life. And if we can find a cure for Wolfram through gene therapy or gene editing therapy, they may stop taking the medication. But in short, patients with Wolfram, they may need to take AMX 35 for life because it's a chronic disorder, just like hyperlipidemia.
Lovely, thank you. When could the compound be available for patients overseas?
Yeah, so that's also that's a bit of a long answer at the moment. Of course, first of all, we have to complete this initial trial, Helios. The results that were shown today were in 8 participants at week 24, so we need to see all 12 participants to week 24 and then continue to follow them. So that's first and foremost the first priority. And then as we start talking about availability, that relies on regulators. So that's people like the FDA, the EMA that Dr. Barrett was speaking to earlier. And we really have to have conversations with them to understand what they want from us. I'm so happy that Dr. Barrett went through, kind of the process and the discussions that were had around the Treat Wolfram trial. As you can see, there were very specific things that came up in terms of how they wanted the trial design, what measures, et cetera. So we have to have those conversations too, to determine what other trials we need to do, what other evidence we need to generate, to then lead to that regulatory approval, which would then, provide access around the world. So short answer is it's going to take a little while. We're working as quickly as possible to do that, but of course we have to see the end result of this first trial and make sure that what we're seeing in the interim analysis, is still true when we look at all participants and at later time points as well too.
Lovely, thank you. Tim, did you want to add anything onto that at all about getting into Europe and?
Just to say that no, it's fantastic. It's lovely to see your interim results, and it's fantastic that your company is really interested in this ultra rare disease. Again, I think it might be worth approaching the European Union initiative called Remedial, and I can do an introduction to the lead for that if necessary. They're very much looking for exemplar trials that are quite mature, which your one clearly is, to actually take through their regulatory processes with support. So you may well be able to get some support for this within Europe through that EU initiative.
Oh, thank you very much. We appreciate that.
Lovely, thank you. We'll do one more question, then we'll finish up for the afternoon, and any of the other questions will be sent out to our presenters. So for the last question, have you started to look at safety of AMX 35 in younger than 17?
Matthias, would you like to start with that one?
Absolutely. Great question. It is the goal of Amylyx to also look at a younger population. We have initiated internal processes, but we have not looked at younger participants in a clinical trial yet.
Lovely, thank you. Does anyone, Fumi, Jamie, do you have anything else to add up to that, or are you happy?
I'm
Right,
happy
so
with
I
Matthias.
want to-
Oh,
Yeah,
go
go
ahead.
Okay.
Please go ahead, Dr. Urano, please.
No, I just wanted to say, we are closely collaborating with Tim Barrett's team. So, Amylyx has been communicating with Tim Barrett's team, and the Dr. Barrett's team will complete their ongoing trial end of this year, so they can potentially work with Amylyx and further test this compound in adults and children, so that the drug may be available in the UK and Europe sooner than we expected. So that's all I wanted to say. Sorry.
Lovely, thank you. Okay, so
Tracy,
yep, Steph, yes.
I just want to throw out a big thank you to Tracy, because she really is the one who organized all of this. I'm just sitting here looking like I did, and I didn't. She did everything. So thank you so much, Trace, for doing this. I know how hard this is to pull off, so I appreciate it.